Hi friends, welcome back to next level ophthalmology. We are starting a new chapter today on sclera. So I would like to start this chapter by paying respects to Dr. Somshila Murthy, Head of Cornea Services in LV Prasad Eye Institute, from whom I learned most of the subject about sclera. Okay, so today we learn about anatomy, embryology and the congenital anomalies that are associated with sclera. Sclera is not a very important chapter, it's a very short chapter. You might get one or two at the most. Okay, one or two questions, that's all. So anatomy, let's begin. Sclera comprises the posterior 4/5 of the outer coat of the eyeball, and in Greek it means stone. So sclera is a very hard structure and it gives integrity to the globe. So it is outer surface is covered by Tenon's capsule, while inwards it fuses with the choroid. Okay, so anteriorly the sclera is wrapped by the conjunctiva, and it has three ill-defined layers, as you can see in the picture here: episclera, sclera proper or stroma, and then the lamina fusca, which then continues as the choroid. So what are the functions of sclera? It forms a protective layer against various stress and strain and gives insertions to extraocular muscles. So what is the applied aspect of this? A healthy sclera is usually white in color. Okay, in children, and when there are ectatic disorders associated with collagen, you can have a blue sclera. So blue sclera is a common congenital condition. So this is blue because the sclera is thin and the underlying choroid is visible. In the elderly, on the other hand, you can have white plaques which may have calcium deposits, and these are referred to as senile scleral plaques. Sclera is a relatively avascular structure and it's composed of dense fibrous tissue. Due to this, the diseases are relatively rare, but once affected, they are difficult to treat and tend to be chronic. So let's take a question at this juncture. What is the thinnest part of the sclera? Limbus, anterior to the insertion of muscles, posterior to the insertion of muscles, and posterior pole. So sclera, remember that the thickness varies from 0.5 to 1 mm, almost same as cornea, but the part of sclera which is just posterior to the insertion of the extraocular muscles happens to be the thinnest part of sclera. So the right answer here is C. So what are the other measurements? At the limbus, it is around 0.8 mm. Immediately anterior to the insertion of muscles, it's 0.6. Immediately posterior to the muscles, it is 0.3, which is the thinnest. And then at the equator, it is 0.5 to 0.8, and it's thickest as the posterior pole, which is 1 mm. So the thinnest is just posterior to the insertion of the extraocular muscles and thickest at the posterior pole. The sieve-like opening in the sclera that permits the entry of the optic nerve is called lamina fusca, lamina cribrosa, lamina propria, and lamina papricia. So we learned that lamina fusca is the innermost layer of the sclera, so this is not the answer. Lamina cribrosa, this is the correct answer. It is the sieve-like opening, it's present in the sclera, which permits the entry of the axons of the optic nerve. So what is lamina propria? It is present in the gut mucosa. It is one of the layers of the mucosa. And lamina papricia is a very thin paper-like bone that is present in the medial wall of the orbit. So the correct answer here is B, lamina cribrosa. In an inside-out injury of the globe, it ruptures at the anterior most part of the limbus because, so here we are talking about a globe rupture. So globe rupture is not a penetrating trauma. It is a blunt trauma causing a open globe injury. So the force of the trauma is so much that the globe ruptures from inside out. So this happens at a very weak point. So anything that is the weakest point in the globe will rupture. So we have to now decide which is the weakest part. The sclera is thinnest at the limbus. Now we know that's not true. The direction of vector forces of trauma. So again, this might be. So let's keep this in mind. There is a relative weakness of the sclera due to the presence of Schlemm's canal. So this is a very important factor here. Just anterior to the limbus, there is a deficiency within the sclera. It houses the Schlemm's canal, which is necessary for drainage of the aqueous. So this area is very thin, and this happens to be a common place where the sclera ruptures. There is a ciliary body which makes the pressure more at that point. No, this doesn't have any logic. So the right answer here is C. So what happens, we'll just discuss about the direction of forces. Suppose this is the globe, this is the cornea. There is a direct blunt trauma, okay, and these forces, they are directed towards the posterior pole, okay. So this is how the vector forces of injury, blunt trauma happen. So there is no force directly acting at the limbus. It ruptures because it is the thinnest part. So what are the apertures that are present within the sclera? We have the anterior, middle and the posterior. The middle apertures are 4 in number and situated 4 mm behind the equator. They allow the passage of the vortex veins. Vortex veins are 4 in number: superotemporal, superonasal, inferotemporal and inferonasal. Then we have the posterior apertures which allow the optic nerve. So this is through the lamina cribrosa. Surrounding that we have long posterior ciliary arteries, short posterior ciliary arteries and long ciliary nerves. What about the anterior apertures? They are around 3 to 4 mm from the limbus. They allow the passage of the anterior ciliary vessels and nerves. So these are various apertures that are present within the sclera. The next question, identify the site of anterior subtenon injection in this diagram. So here the options are A, B, C and D. So A here is topical medication, so this is not an injection at all. So we have ruled out A. B is an injection that is going directly into the vitreous cavity. So this is an intravitreal injection, so this cannot be the answer. C, this is a subretinal implant, so it cannot be the answer. This is not an injection. So here what you see, D is the right answer here. There is an injection going into the subtenon space. Subtenon is between the tenon's fascia and the sclera. So this forms an important place where you can give depot injections because there is a small space there which will allow the drug to settle down. The sclera is basically derived from the fibrous layer of the mesenchyme that surrounds the optic cup. The anterior part of this stroma forms the cornea and whatever is posterior forms the sclera, okay. So how is sclera different from cornea? Both are made up of collagen, but the collagen fibrils are very regularly laid in cornea, whereas in sclera these are haphazardly arranged. So whenever there is hydration of the corneal stroma, there is opacification. Whenever there is hydration of the scleral collagen, you get translucency. So these are the two important differences between the histology of sclera and cornea. So now let's move on to congenital disorders of the sclera. So identify the disease that is not associated with this feature. So the picture here shown is, it's a congenital condition called as blue sclera. So blue sclera can be caused by a variety of conditions. So we are asked to identify a syndrome that is not associated with blue sclera. As osteogenesis imperfecta, yes, it is associated. Ehlers-Danlos, again a collagen vascular disease is associated. Pseudoxanthoma elasticum, again associated. Wood-Carnage-Harada syndrome is a chronic granulomatous inflammation that is not associated with the blue sclera. So the answer here is D. So what are the other conditions? So we can have an acronym here: P poem, P pseudoxanthoma elasticum, Paget's disease, osteogenesis imperfecta, Ehlers-Danlos syndrome and Marfan syndrome. So these are the conditions that are associated with the blue sclera. These are systemic conditions. There are ocular conditions to which I will come later. Let's take a question now. A 50-year-old lady presented with a cataract to the outpatient department. On examination, there was pigmentation of the sclera, episclera, that cannot be moved over the globe, and there is also associated periocular skin pigmentation. If you can see here, there is some amount of pigmentation. What are the possible ocular associations? So first we need to know what we are looking at. So we are looking at something known as nevus of Ota or oculodermal melanocytosis. So what are the common associations in this? You can have iris pigmentation, hyperpigmentation, iris mammillations, trabecular meshwork pigmentation, uveal hyperpigmentation, fundus hyperpigmentation, and they are predisposed to developing melanoma. Okay, they do not have coloboma. Coloboma is a condition which results from improper closure of the fetal fissure. Hypopigmentation is not there. There is actually hyperpigmentation, and there is no congenital cataract. So the right answer here is uveal melanoma. This is a condition known as nevus of Ota. A short structured lady presents with pain and redness in the eye. She has short stubby fingers. Okay, on examination this is a small anteriorly subluxated spherical lens. So we have an important clue here. So there is something known as microspherophakia. The lens is small and spherical. So it usually, there is a zonular weakness associated, so it easily subluxates and even can cause angle closure due to the subluxated spherical lens. So systemically they are saying that she has short stubby fingers, so and she's a short statured lady. So probably we are dealing with something known as a Weil-Marchesani syndrome. Okay. So Weil-Marchesani syndrome is characterized by short stature, short stubby fingers, and microspherophakia. What is expected in the sclera? So the correct answer here is blue sclera. Scleral plaques can be a part of aging. This is not the answer. Nevus of Ota or oculodermal melanocytosis is not seen in Weil-Marchesani, and again you won't get staphyloma. So the right answer here is blue sclera. So what are the conditions where you can get a blue sclera? Whenever you get a blue sclera, look at the cornea. Is it an enlarged hazy cornea? Then probably you are dealing with ophthalmos, okay, or congenital glaucoma. If this blue sclera is associated with a normal anterior segment, then you look for a systemic disorder, and the list has been told to you previously. Then if you have a blue sclera with associated bulging of uvea, then it is known as a staphyloma. So that's all for today guys. We'll meet you next week for the next class. Thank you.